Let me start by thanking the organizers first for the privilege of being able to share some of the experiences and lessons learned of a pilot program in Zimbabwe integrating HIV and nutrition services. Before I move on to a description of the program, I wanted to flash this slide to make sure we have a common understanding about integration, because integration means different things to different people. To some people, when they hear integration, they think about integration of types of services from different departments, or preventative and curative services, or even health and education integration. Others are thinking about integration at the point of service delivery, or about integration over time, or across the healthcare systems level, including the policy management level. The WHO definition sums it up very nicely, speaking actually to all of the aspects above. And it's a good thing to keep in the back of our mind as we're moving on through the presentation. So why are we here today talking about integration when we could all be heading downtown for a nice dinner in Melbourne? We all know that resources are defined, and we have an obligation to use the resources as efficiently as possible, and it has been alluded to plentiful in this conference, talking about implementation efficacy. And there is evidence that has linked integration to an increase in service uptake for the same financial input. Funding of single disease programs or population group-specific programs is popular with donors. And the measurement is easier, yet the measurement and the outcome of those programs actually depends on common service delivery resources. We've heard in the opening ceremony yesterday from Michael Sidibe that in order to end HIV, we could not leave anyone out. So that means taking the services to the client, being client-orientated. It's one way of achieving the goal of universal access. For some of the smaller programs, integration just simply means survival. So why not integrate everything everywhere? There have been concerns that integration could lead to a reduction in the quality of service provision. So if a nurse has to provide different services at the service delivery point, that might be at the expense of the quality of the services. It's much more difficult to showcase achievements. How do we measure integration, and how do we link the integration success to coverage uptake? And then there's the issue about the special case around HIV/AIDS services. It was pushed forward to make sure that HIV services can be expanded quickly and continue to be well-resourced. This program specifically looks at the integration of HIV services, and here I'm thinking PMTCT and pediatric HIV services, with nutrition services, including infant and young child feeding and CMUM services. Why HIV and nutrition services? Because they're mutually dependent on each other. We know that advanced HIV disease is associated with a reduced nutritional status, and good nutrition slows HIV progression. So although these two services are mutually dependent on each other, they're largely implemented in a vertical manner, and we're missing potential opportunities to maximize services here. So in order to find a way how to integrate the two services and what the outcome was, a 3-country program in Zimbabwe, Malawi, and Mozambique funded by Canadian DFAT through UNICEF, was implemented over a time frame of 3 years, July 2001 to June 2014. In Zimbabwe, the pilot program was implemented by 2 local organizations in close collaboration with the Ministry of Health and Child Care and their respective HIV and nutrition departments. I'm presenting here the results of the implementation of Offit Trust, which was implementing the program in 2 districts in 32 sites. This slide here summarizes the different activities that were conducted within the integration project. And as you can see, much in line with the WHO definition that I flashed earlier on, there were integration activities across all levels of the healthcare system, including from managerial policy level right down to taking the services to the client with integrated outreach services and activities at community level. An emphasis was put on the provision of all services, of complete service packages at the service delivery point. But integration also extended into our monitoring and evaluation. To monitor the delivery of service integration, we defined specific integration indicators that measured the concurrent provision of HIV and nutrition services. I put here 2 examples to illustrate that there was the integration of HIV services into nutrition services. So that's bringing in HIV services at the point of nutrition service delivery. And the other way around of introducing additional nutrition services at the classic point of HIV service delivery. So examples for that are, for example, if children are treated in a pediatric ART program, to bring in the nutrition services would mean that they're screened for SAM. And vice versa, for children who are treated for SAM, it was checking their HIV status. The next 2 slides look at the outcome of the program. The first slide looks at indicators where nutrition services were brought onto the HIV services. And the second slide will look at HIV services added onto the nutrition services. Without going into detail in the individual indicators, you can see that over the period of the program, and these are the data of 2 years from January 2012 to December 2013, there has been an increase in the uptake of the integrated services. What is also interesting to note is there was a baseline level there already. So it isn't as if there's no integration taking place at the moment. It's there, but it's not being measured, and it has potential for improvement. So we have shown that through a number of activities to promote integration across all healthcare service delivery levels, we can increase the provision of integrated services from a baseline that is there, promoted through the interventions and promoted to bringing in an M&E system monitoring the integration. Integration can become a success story. What were the challenges? Challenges were there particularly at higher level. Working with different departments at national level can be a sensitive issue. There were monitoring and evaluation challenges. Combination indicators that look at two services that are provided concurrently are inherently more complicated for healthcare workers to understand and record correctly, more complicated because in our case, they were not routinely recorded and not available in one register. And sometimes they were even referring to indicators that weren't routinely, partly indicators that weren't routinely collected. So for example, we don't usually collect information on infant and young child feeding. What are the recommendations? We need to continue the integration efforts at national level, even if they may be fraught with difficulties. And we need to pay more attention to the national routine M&E tools to include measures for integration and set targets for these integration indicators. The next steps specifically for this program are an impact analysis that we are actually looking how this integration project translated into number of pediatric infections averted or number of life years saved, and then link it to a cost effectiveness analysis as well. Thank you very much.